please join me in providing a warm welcome to our esteemed speaker, Dr. Wyatt.
Good morning. Good morning. Thank you so much for the nice introduction. And thank you all. I wish that you were here. Maybe I wish y'all wherever you are. Not sure. But welcome. Thank you for taking the time to listen to me. And right now I'm making sure that as I get started, that we have the right presentation. So let's see. So that's a little bit more about the organizations that I currently work with, primarily around healthcare equity, patient safety, and quality improvement. Currently, I'm working as Chief Science Officer and Chief Medical Officer for the Society to Improve Diagnosis in Medicine. These are the objectives for this morning that we hopefully will go through. And if I can, I'm going to pause here for a second. So I'm going to pause for a second if I can. This is not the right slide deck. So let me let's pause for a second and see if we can get the right slide deck going.
All right, just give us a few minutes. We'll pull up the right slide deck. Okay, everyone, I think we're back. Sorry again for that little delay. We'll go ahead and get started. And we'll still have time for questions, so thank you again.
All right. Thank you. And we'll get started. Again, some of the organizations I work with in some form or fashion. These are the objectives for this morning's presentation. Again, I won't read through them, and you're more than welcome to have these slides. So I'm just going to start here because I think it's always important in these presentations, and particularly in grand rounds, that there is some case to talk about, some person that has been impacted by healthcare. So about a year and a half ago, I wanted to see an internist for the first time. And, I'll just say that the exam that I received was subpar. After the visit and some laboratory work, I received a MyChart message saying that I needed to be on a statin. So I put my numbers into the calculator, and probably I would barely be a candidate for a statin. And so I sent my questions back through MyChart for my internist. And after 3 months, the nurse responded to my message and did not answer the question, which was, why do I need to take a statin? I waited a year. When I went back in for my physical exam this past December, I asked the internist, why do you want me on a statin? And he went through some of the kind of evidence-based answers for it. I said, well, but when I was here, you did my electrolytes and glucose and some other things, but you didn't check any of my liver function tests. You didn't check a CPK. And you sent a message saying that you want me on a statin. So I said, so if I'm going to start the statin, I'm not opposed to it, but I know about how many additional days of my life I would get from taking a statin, as opposed to diet, exercise, and maybe raising my LDL a bit above 140. So his answer to me, as he looked at his iPad, was, oh, we can do a CPK for you because you have really good insurance. That's not a good answer for interns to give a patient. You have really good insurance. So I would expect that as you practice medicine, you practice based on evidence and science, and remove your own personal cognitive biases from the decision making, and make the best decisions you can make, because the mistake that he made was what I would call a diagnostic error that was embedded in personal cognitive biases. And if you look at ECRI's data from last year, it says that cognitive biases and diagnostic error lands in the top 10 patient safety concerns for that year. And then my most recent employer was the largest medical malpractice company in the United States, MCIC Vermont, which is owned by 5 academic medical centers. And when we looked at the data from Coverage, which we use, it tells us that diagnostic related failures still remain the single largest root cause of medical malpractice claims. Well, people know this, and I introduced that story because people know it, just like I knew that there was a problem. Patients recognize the problem. And that's what this data from U of Chicago and IHI depicts. People know that a medical problem was not diagnosed correctly, that there was a mistake made, that the diagnosis didn't make sense, or that people were not being treated with success. But what we're really after, and I would say in internal medicine, my bias, more than any other specialty, is diagnostic excellence. As interns, we are diagnosticians first. So diagnostic excellence remains what we should be focused on, and that it remains in our aims of being timely, cost-effective, convenient, and understandable to the patients. It becomes a patient safety issue and it's not received the kind of attention I believe that it should receive, and that we need to focus more intently on evidence-based approaches to diagnostic safety. Well, inside of that then, and we'll spend more time talking about, is the idea of achieving and advancing diagnostic equity. So when we think about equity, then we think about unwarranted variations in our diagnosis based on some other factors, social, economic, demographic, geographic, political, or whatever it might be, that we think about diagnostic equity. And what the data says in this study from Hardeep Singh and some other people is that 1 in 20 adults experience some diagnostic error in the outpatient setting every year. And in a previous life, I was the first patient safety officer at the Joint Commission. And we analyzed every sentinel event and every harm event that was reported to the Joint Commission. This is the most recent data from the Joint Commission, the leading sentinel events from 2018 to 2022. And what you will see is delays in treatment remains on that top 5 list. And this is looking back. I actually went and looked back 10 years. And when I look back at 10 years, delays in treatment remained in the top 5. And you'll see the top 10 leading sentinel events in 2022. So that we all know what a sentinel event is. That's an event in the process of healthcare being delivered that results in death, permanent harm, or severe temporary harm. So then if we take a closer look at the sentinel event data, just looking at delays in treatment, what you'll see here is how that's broken down when we say a delay in care. And what you see, there's almost 40% of these sentinel events are misdiagnosis. Well, as we begin to think about these issues in diagnostic excellence and diagnostic equity, we have to spend time on history and not continue to be ahistorical about how we practice and deliver medicine and diagnostic equity. So these are just some examples of historical facts that many of you probably already know about. One is the physician who was for a long time called the father of modern gynecology from Alabama, where I'm from, who practiced and perfected his surgeries on enslaved women. Many of you likely know about the syphilis studies that were done in Tuskegee, and I practiced medicine in Alabama and St. Louis for about 25 years. The echoes of Tuskegee and the syphilis studies still ring there. There's still an echo. There's still a level of distrust and mistrust because of those experiments. I think many of us know about the mortality gap between white women and Black women, what we now call birthing people, that has existed for over 100 years. And then many of us know about the COVID pandemic unveiling what many of us already knew about healthcare in the United States pre-COVID. So the combination of COVID, the killing of George Floyd and Breonna Taylor, all were catalysts to say we need to take a closer look at race and medicine and healthcare in the United States. So then we have to change our perspective. What are those old questions around the work that we do? And I'm specifically now talking about internal medicine. Those old questions, those ILM questions, is the care safe, effective, patient-centered, timely, and equitable? And equitable care, we talk about as being the forgotten aim from the ILM aims. And then the new question then becomes, and you will hear this increasingly as your careers progress for those in training, how will we improve the value of the care that we deliver to people, communities, and societies? I talked earlier about this person before we went live. This is Joe Sapira, who I spent a lot of time with in training, Joe was writing this book when I was a resident, The Art and Science of Bedside Diagnosis. I would encourage you, those that are interested in this, to get the book and read what Joe would talk about. Probably one of the best bedside diagnosticians ever. You can learn a lot about the art and science of bedside diagnosis, but why I bring this to you is that Joe's interaction with people, the empathy and the respect and the compassion that he showed to people, and as trainees, we would be up all night on call, chasing down labs and diagnostic test results and questioning the patient. And the next day, Joe would come in, go to the bedside, ask the patient, what's wrong with you? And out would come all this information And we just standing there shaking our head like, we've been asking that all night. And just thinking about that person interaction. And what I didn't know at the time, and this is a repeat of that slide, is that Joe was practicing diagnostic equity. And part of his success in diagnostic equity and diagnostic excellence was the ability to be humble and to listen to what people were saying to him. And then putting together the facts and the data to make the diagnosis. Well, why don't we make the diagnosis? And again, we're talking about diagnostic equity. What happens to us at the bedside or in a virtual space? One is what's called problem blindness. And another way to think about that is anchoring bias. Some call it expert opinion. The other one is lack of ownership. When people will say it's not mine to fix. Or then what's called tunneling, where we have so many different things going on, especially during these days of COVID, that we have a lot of different problems that we're trying to solve. And we are challenged to solve all of them as we're on this quest for diagnostic equity. So then what are some of the things that we continue to have to recommend and to think about? One is we have to have a bias. If there's a bias in diagnosis, that bias should be towards action, that we need to do something. And part of that something is understanding a system and moving upstream to find out what are those things we can do to improve outcomes for people. Start at the micro level and go to the macro level. And we talked about this some yesterday, that we think about boiling the ocean and there's so much that we have to do. And what I emphasize to you is start with one person at a time. If you can help that one person at a time, then you can move to helping a population. And then think about scoreboards over pills. And this is in this paper that's called The Quest to Solve Problems Before They Happen. So being proactive about what we do, not just treating something that we're not sure about. So taking ownership of a problem, persisting in that problem, not obsessing about the perfect, but not being swallowed up in what's called analysis paralysis. Well, part of this work then is that we have to begin to identify and act on root causes. So when we think about diagnostic equity, these are some of the factors that we work with, and I would say are probably the leading 5 root causes that prevent us from achieving health equity. This is a report from ECRI that I was fortunate enough to do what's called a deep dive on a couple of years ago. And what ECRI again found was that of the top 10 patient safety concerns in 2022, bias and racism came out as number 3. And you'll see some of that data in there. So you will see later on in the presentation how all of this has come forward to say, here are some things that we need to start to think about. So then if we think about inequity as a patient safety event, go back to my definition of the Sentinel event. If we think about a patient safety event, what that means is someone was injured or hurt or harmed in the process of receiving healthcare. And it always starts with people in the community, and then it goes downstream to something happened. A safety event occurred. So then when we put that into a fishbone diagram or Ishikawa diagram, we began to ask the question why. And we asked the question why 5 times. And when we look at events around inequity, again, these are some of the areas that continue to emerge when a proper root cause analysis is done, beginning to address racism in the care that we deliver, addressing stereotype bias. And you see some of those contributory factors there. Do we understand, and how are we addressing unconscious and implicit bias? What is workforce capacity? And how are we addressing workforce capacity if that's one of the whys to how people get harmed? The next is resource allocation. And on the resource allocation, those contributory factors, some of them are training, supplies, and equipment. So those are what we call latent conditions that hurt people. And the question becomes, are those resources being allocated in an equitable fashion? And many of us have heard about, I'm sure you have, diversity, equity, inclusion efforts. Some now call it diversity, equity, inclusion, and belonging. And what does that look like in an organization? where is there a lack of diversity in an organization? It could be race, ethnicity, language. It could be what I call povertyism, ruralism, sizeism, and ageism, among all of these things that contribute to lacks of diversity and equity in an organization. So just a listing now of those contributory factors that are at a system level, a provider level, and a patient level. And again, you can have these slides and look at what those contributory factors might be in a system. So the first question becomes, then in a system, in any system, when we talk about inequities and measuring inequities in a system, the first question is, how does inequity operate in your system? And look at those factors. How does inequity operate at the clinician level? How does it operate then at the patient and community level that we'll get into a bit later, that is increasingly and is accelerated in its importance and how we deliver care and honestly, how we get paid for that care. But then if we think about then first implicit bias, here's a nice framework for medical education. And I highlighted that one box around implicit bias and how it impacts behaviors and outcomes. So addressing where the health disparities exist in your system, having a robust reporting system that is used, that errors are reported, that the errors are acted on, that corrective actions are taken, and that learning is then shared across the entire system, particularly if implicit unconscious bias is one of the contributors. The other thing that we have begun to talk about and act on is what's called race correction medicine. I had a conversation yesterday with someone about just race correction medicine. And I would say that there is not a specialty in medicine that is not some way or another impacted by race correction, whether it's cardiology, nephrology. I think many of you know about the efforts to change the EGFR around kidney care. We see it in every specialty, and we're beginning to correct that. Likely you know about the issues around pulse oximetry and the FDA alert that says we need to look at how we make decisions about pulse oximetry in people who have darker skin. And what does that mean in terms of clinical decision making? So if you're not aware of that one, again, read the alert, and it gives more information about how racial bias has played into pulse oximetry readings. Well, then what purpose does bias serve, especially when we're under production pressure in a pandemic or whatever the next black swan event is going to be? When we're in these events, the concept of thinking fast and slow takes over automatically. And what we find is that bias ensures our survival. We have an automatic reaction, and then we become more comfortable, and the data bears this out. We become more comfortable with people who are like us. The next concept that we'll talk about is what's called structural competency. That's increasingly being taught at ACGME. We do a lot of discussion about structural competency. Some of you may know of the so-called social determinants of health. We'll talk about it a bit later. But inside of structural competency, that means in a clinical setting, and this is down to the exam room level, when people come to see us, people bring their historical trauma with them. That people bring their social, their political, their economic selves with them. And we have to do a better job of understanding how that impacts healthcare, health outcomes, and the interventions that we recommend for people. As you see in some areas, that povertyism is a real issue, especially childhood poverty, and the impact that it has on chronic disease later on in adult life, and how it decreases life expectancy. And again, whatever those health outcomes that the data in your system says that must be addressed, and we'll talk more about accreditation later, that now we, under accreditation regulation, we are now required to look at a particular health outcome and work on it. We cannot ignore the impact of structural and institutional racism on healthcare and health equity and diagnostic equity. And this is not what we call interpersonal racism. This is structural and institutional racism that exists in many systems. So the question becomes, then how does that operate in a system? And what are we doing to correct institutional structural racism that impacts clinical decision-making? The next area, and I encourage you, if you can read this paper, we talked about the lack of trust, mistrust, distrust, no trust in healthcare. And that is not just from people and patients to clinicians. It's clinicians that don't trust each other. It's clinicians that don't trust leadership. It's leadership that doesn't trust clinicians, nurses that don't trust physicians. All the phases of trust are challenged now more than ever. It's what's called a trust decay. And that drove us at the American Board of Internal Medicine Foundation. So we really need to commit inside of health equity to building back the trust that's been lost. That there's something called a trust decay. Trust decay is when there is a lack of empathy. Trust decay is when judgment and logic and decision-making is somehow not equitable and it's not applied the same to all people. The next is, are you genuine and authentic when we engage with people and communities? Is it genuine? Is it authentic? Do you care more about the people coming to us for care than you do about yourself? So those are just some of the three main components of building back trust. When we wrote the paper, these are the areas that we talked about, and I underlined in medical education and training the things that we must think about. And in medical education and training, we're saying move this into the clinical learning environments. This is for students, for trainees, and faculty, making sure that the environments of learning are safe and inclusive, that they're equitable, that diversity is supported, that the protocols related to any kind of ism, depending on where you are being addressed and people are being held accountable, that there is mentoring so that we can develop diverse leaders in academics and research and other extracurricular activities in a community based on your community. And then what are those education professional development tools that are needed? So that gets back to what we talked about earlier with latent conditions. Are these things being supported inside the organization? Are we looking at what are the best available approaches, methods that will surface and dispel bias and discrimination in the care that we deliver? That leads into the ACGME's Equity Matters program. And we're now in the third year where I'm faculty on this program, primarily based in Illinois, but it will spread across the country. And there are hundreds of people involved with this work, many institutional officers involved with this work, where we're saying the aim is to achieve health equity by increasing workforce diversity, building those learning environments. So we have these sessions monthly with leaders and organizations that are sponsored by the ACGME, and interestingly enough, also co-sponsored by Blue Cross of Illinois. That becomes really pertinent because the big commercial payers are increasingly looking at how we deliver equitable care. This is just an example from Chicago and a good friend of mine, David Ansel, about how they began to partner with a community. And just as an example of those mission anchor initiatives there in Chicago, but you can apply this to the community and to the region that you're in here. Have you thought about starting anchor missions for the populations that are served in your service area? That feeds back into the Medicare and Medicaid equity strategy. And these are those priorities. I won't read through them, but these are the things now that CMS is saying must be put in place in order to address health equity and the failures inside of health equity that are so crucial and so critical. I will say priority number one is data. How we began to collect, report, analyze data in order to make decisions that are more equitable. And late last year, CMS issued its final rule for hospitals around health equity and maternal care. And these are the components. These are now federal regulations, what hospitals and outpatient settings know of as conditions of participation in CMS, Centers for Medicare and Medicaid. So now CMS is saying there must be a commitment to establishing a culture of equity that includes these 5 domains that are inside of that Medicare slide that I just showed you. There must be strategic planning around health equity. There must be a method of data collection, data analysis. There must be a demonstrable program around quality improvement and how quality improvement methods and techniques are taking place inside an organization to address whatever the inequities are in your system. And there must be leadership engagement in these domains in creating cultures of equity. The second and third measures there are what we call the drivers of health. Some call the social determinants of health that are identified down to the patient level, where people are screened for these drivers of health. This includes food insecurity, housing instability, transportation insecurity, utilities difficulties, and interpersonal safety. So all of those now, when people are risk assessed for each of these, and if these are identified, then through conditions of participation, a system now must have a plan to address these issues. I'll give you one example from a system that I work with in Boston around utilities difficulties. And in this particular system, they assess, this is a children's hospital in Boston. They assess the home situation before that child leaves the hospital. The legal team is brought into this process. And if it's determined that the home, if it's a rental property, if that home does not have utilities, or if the utilities company or the landlord is not providing utilities, then that children's hospital has started to bring legal action against a landlord if that place is not fit for children to live in. The drivers of health are being adopted. These are just some examples of what we talked about. CMS, states, private insurance plans now are all looking at these drivers of health and how we are or not improving health outcomes. And again, these are just some potentials that you may begin to think about for those that are interested in population health, patient experience, improving outcomes, meeting the regulatory requirements, then establishing what your measures are going to be. I will say that at the top and the most critical, the most important, the first one that CMS and payers will look at is, are you collecting, validating, analyzing race, ethnicity, and language data, sexual orientation and gender identity data, and those drivers of health information just as a structural measure. And then what CMS is saying, we want to know what your screening rates are for your processes. If someone screens positive for one of those high-risk drivers, then what's your process to address? You may have to present to CMS or payers, what is your rate of navigation around people who are eligible to receive navigation services, just as some of the examples. And again, what's the unmet need in your population? You may decide that there's food insecurity or one of those other ones that we just talked about. This is just a screenshot of the value-based purchasing domains from CMS that other payers are rapidly adopting. So 4 areas that are all weighted the same at 25%. At this most bluntest is knowing what your risk-adjusted or your hospital standardized mortality rate is, and are you stratifying it by race, by ethnicity, by language, by insurance status, however you stratify that to get a better idea of what's driving mortality in your population. And then you see some specific measures that we are required to report. Under person and community engagement, this is what many of us will know as the HCAHPS data, also weighted at 25%. And increasingly, we're being asked to, again, stratify that data by race, ethnicity, language, insurance status, et cetera. Under safety, it's all of those, almost all of those are hospital-acquired infections. This is the one where the benchmarks are set by the CDC and what's called NHSN, which is the gold standard. And you'll see by those benchmarks, there's only one of them that the benchmark for hospital-acquired infection is already zero. Zero. The only one that's not, you'll see there is C. difficile infection. The other one that's required reporting is what's called patient safety indicator 90. That is a composite of multiple patient safety indicators that come from the Agency of Healthcare Research and Quality. And you'll see also that the benchmark that CMS and other payers will look at as you design quality improvement measurement plans, that these benchmarks are there for us that we have to meet and be in compliance with. Efficiency and effectiveness is a little bit more challenging to understand, but I'll give you an example. And the example I typically use in this one is, what is your readmissions rate? What is your unplanned readmissions rate and for 30 days? And what is the cost of readmissions? Are you being rewarded or penalized for your readmissions rate? And around readmissions, do you have a care transitions program? Do you have social services support? Do you have navigation services? What is the cost to the system of an unplanned readmission? And how are you addressing that inside of your quality improvement plan, which is also part of the original, what's called the triple aim. Now is the quintuple aim. For those that aren't familiar with that, I would encourage you to go back and read the original triple aim paper. And one of the aims is how we reduce per capita costs inside a population. These are, I won't read through them. These are the Joint Commission new equity standards. The standards went live back in January. So you may, those interested in accreditation regulation may want to read through those. I wrote them about 1.5 years ago. And now they are standards that we will all have to be in compliance with. Coming in July, not far off, is a national patient safety goal on health equity. Some colleagues of mine and I wrote the National Patient Safety Goal for Health Equity in 2015. So it's taken kind of that long to get to where we are. That really becomes a game changer inside an organization. So I would say those in leadership and regulatory accreditation, patient safety, and quality improvement to be really familiar with a national patient safety goal. A national patient safety goal now becomes a condition of participation with CMS. And those standards inside of that, those standards and those, what it says, 6 EPs. EPs are elements of performance. So when you get a Joint Commission survey, and I'm a trained Joint Commission surveyor, we will look at those 6 elements of performance to see if you're meeting them. The big deal with the National Patient Safety Goal, again, is that if you fail to meet those elements of performance, then that becomes a condition level deficiency is what it's called. That's reported to payers, it's reported to the media, it's reported to the public, it's reported to the health department. So it becomes a really, really big deal. Also now, I won't spend a lot of time with is the Joint Commission has started a health equity certification program along with NCQA and some others. So why is this so important when we begin to think about just the human toll of inequity? This is from a Deloitte study that says by 2040, inequities alone, whatever they may be, it may be mental health, it may be opioid use disorder, it may, whatever it might be, it's gonna cost us, and this, when I say us, because this is our money, it will cost $1 trillion by 2040. Right now, it's over $330 billion, that is per year, the cost of inequities in our system. So again, it becomes urgent that we begin to address inequities in a system based on what the inequities are in your system. So that's the urgency of it. So as I wrap this up, then think about these major factors. We started with history. So making sure, what is the history of this system? What are the histories of inequities in this region and in your system? And how are some populations advantaged? How other populations disadvantaged based on how the system is designed to operate? Think about what Kamara Jones, my good friend, calls a myth of meritocracy. Part of this is that we're really not in a place where someone has earned something more than someone else through meritocracy. That is a myth. It's a myth to say if you work harder, you'll make it. That is just simply not true in the system and how it operates. The other one is that we're not in a zero-sum game. So part of the work that we do in health equity, safety, and quality is not to take from one population to give to another population. It is to improve population health for all people. So that is not a zero-sum game. If you haven't seen, I would encourage you, this is a paper we wrote with some friends some years ago on a strategy. If you are interested in achieving health equity, much of what is in the CMS conditions, the Joint Commission standards came from this paper that was written back in, I think, 2015, 2016, that gives a strategy for quality improvement efforts around achieving health equity. The first and foremost one is that you make health equity a strategic priority, that you build the infrastructure, that you address what we call the multiple determinants of health, what we refer to here as the drivers of health, what some call social determinants of health. That we look at what are all of the forms of oppression that operate inside the system, whether it's racism, whether it's, again, povertyism, ruralism, what are those forms of oppression that we need to address? And then, as we say, we can't keep doing things to a community without the community. So partnering with communities, listening to communities, understanding what matters most to a community, then coming back and designing a system that are going to meet those needs that are sustainable. And those are some of those recommendations. I won't read through them, but again, I will say, beginning always with, is leadership committed to these issues that I've talked about? Is leadership committed? Is it being messaged? Is it being resourced? How does that take place? Is your data accessible? Is it valid? Have you analyzed it? Is it actionable? Along whatever those demographics are inside of your system that says, here's where disparities live, here's where inequities exist. So I'll finish by saying this. I think many of us know that internal medicine is hard work. It's learning, it's pressure, it's volume, it's long hours, but it's hard work. So I always finish with this slide to say, especially in internal medicine, is what are you committed to? Are you committed to doing good? Are you committed to being aware? Are you committed to staying awake on these issues? Will you commit to doing good? And I go back to Dr. Sapara on this part of it. As difficult as Joe Sapara was, he would say this: we have to do good for people, listen to what people are telling us, and then work to make this world a greater place. And that is hard work. That's not hard work. So I appreciate you listening to me. Hopefully I'll have some questions for this session. And I would encourage you to continue to learn and to grow and to do good. And I say thank you.
Pull up the chat here really quick. Thank you so much, Dr. So I encourage people to go ahead and put your questions in the chat. And then also, if you have any questions, just let us know and you can unmute. We have one that says, excellent topic and talk. Yes, it's hard work and acknowledge, accept, adapt, and act.
Dr. Wyatt, my name is Amir. I'm one of the PCCM faculty. Thank you for this wonderful talk. So I know you have covered quite a lot, but what are the lowest hanging fruits that are the easiest to do so that we can actually make a change?
Dr. Abdullah, we couldn't hear you. Would you mind if just try to put it into the chat and we'll read it off? Sorry, it sounds like the connection's a little fuzzy on our end. Do you want to try to repeat it as well?
I put it in the chat group as well.
Oh, okay, good, okay. So now that's a good question, an interesting question. And you know, when we think about based on the presentation, I'll say two areas: diagnostic excellence and equity, and inequity. There is not so much low-hanging fruit as there is fruit on the ground. So if we start by picking up the fruit on the ground, then we'll get to the low-lying fruit. The fruit on the ground is your data. What is the data saying? And if you just start with, go back and look at the slide on value-based purchasing, and look at those domains. That's the fruit on the ground. What is the risk-adjusted hospital standardized mortality rate for the population that you serve? My understanding is in this area, there's a big problem with opiate use disorder and the decrease in life expectancy because of that. What are those drivers? And then how can a system help a community, a region, and a state? Obviously, one healthcare system can't solve that, but that is an area to think about. Where is it that you can start? How does that impact your healthcare system? What is the cost? And that's both real green dollar cost, but the cost of the future of a region. So if you look back at the triple aim, and it talks about people experience and population health. So that's one area. The other one is if you can get the data, and I tried to find some of the data for this county this morning, what is the child poverty rate? And how will that impact, how is that impacting health and healthcare now? One of the metrics that you can possibly get that is probably in the public, that's a good signal, is how many children are on a free lunch or breakfast program. That's a real big marker in a community to say, what are those drivers out there in this regard? We looked at this number in Cook County in Chicago, and that's, you're talking over 2 million people. And we looked at school attendance, and we shouldn't have been surprised, but we were. In the Cook County public school system, the day of the week with the largest number of children coming to school was Monday. It was Monday because many of those children did not have anything to eat over the weekend. So they were on the free lunch program. They would come in on Mondays so they could get a free breakfast and lunch. And for many, that breakfast and lunch was the best meal they would have that week. So if you look at program indicators like that, then it starts to give you a place to start to understand how it impacts your healthcare. Another area, if we get more complex about it, with adults and children, you can look at your immunization rates. And what are the immunization rates, particularly again for children? What are we doing about asthma control for children? Then you can move up higher and look at breast cancer screening, colon cancer screening, hemoglobin A1Cs. If you look at HEDIS data, and if you have HEDIS data, that's another place you can look for the more low-lying fruit as opposed to fruit on the ground. So those are just some ideas about where you can begin to start inside of a population. The other one I encourage is whoever looks at your HCAHPS data. I think here you use Press Ganey HCAHPS. And what we did again at Cook County Health System of Chicago is not just look at your HCAHPS data, but look at the narrative. What are people saying? And inside of the narrative, we've just found just all kinds of opportunities to improve care for people we serve, including lack of interpretive services, conditions of care or environments, people that said that the care teams were rude or disrespectful. That came through in the narrative, not in the HCAHPS drop down, check the box. So there are lots of opportunities out there to begin to think about how it's going to impact your system. Again, that fits inside of that rubric of value-based purchasing.
Dr. Hogan had a comment there, or question.
There's some common patient inequity that you encounter in our area. Some West Virginia W, some success stories that you want to share.
So I'm not from the area, so I can't share. Maybe somebody else can. But I would just say this. In the conversations I've had just in a day and a half was around poverty. It was around opiate use disorder. It was around people who are driving 2 and 3 hours to receive care. So that gets back into, if you again look at the CMS conditions, one of them is transportation and security. And I'll give you an example from, I was an improvement advisor at Tufts in Boston for their readmissions work. And what we discovered when we thought in all of our smartness and arrogance that we had solved the problem for readmissions for heart failure. What we discovered as an unintended consequence was, and we had hardwired in high-risk patients with heart failure would be seen again within 72 hours of the discharge. What we discovered is there were elderly people who had heart failure that would live 50 or 60 miles from Boston. So then to impose on them coming back into Boston for their follow-up when they didn't have adequate transportation, had to pay someone to bring them back, or was just a challenge to get back, was an unintended consequence. So always look at the unintended consequences of your population, then how can you meet those? There we met it through more virtual visits. We met it through visiting nurses and community navigation services, that someone could lay eyes on that person in those 72 hours, as opposed to saying to them, you need to find a ride back into Boston. That, you know, trying to get back into Boston from 50 miles away, you would say takes an hour, it could take 3 hours because of just traffic. So all of those things you have to consider, and that's what I mean by how does your system operate?
So Dr. Wyatt, to this next question here, and I think this is a common response to these types of discussions, is the concern that a lot of these social inequities are bigger problems and a hospital system may not be able to directly impact them.
Right.
And I certainly understand that perspective. It can seem quite daunting. Maybe you could give us an example or of a program or two that you've seen that was very effective in helping in some way to help people get an idea of what you're talking about.
Yeah. So I will send the paper around, but I just alluded to it in the presentation. If you look at the work that Rush has done in Chicago, it's called Westside United. That's been, I think Westside United has been running now for 8 to 10 years, but those, what they call their anchor missions. So you can determine what those anchor missions are for this system and who you can partner with. And Westside United has partnered with multiple hospitals, community activist organizations, social service entities, religious entities, political entities, and put it inside of this anchor mission. So if you take a close look at that, and that's why I put it in there, that you can begin to think about how a health system fits inside of a mission like that. And in about 3 weeks, I'm headed back to Kansas City, where they're doing something similar in Kansas City as a region. The medical schools are involved, the academics are involved, the community hospitals are involved, community activists, the health department, employers, multiple entities across multiple sectors are involved in the effort in Kansas City that started from Blue Cross and Blue Shield. Even Cerner, the electronic health record company that's based there, is involved with that effort. So that is a collective and a collaborative. And it's a really good question, because it's easy to get discouraged if you say, how can we solve this as one healthcare system? Let's just be blunt about it. You cannot. But as a collective or a collaborative, you can at least start. It's the way they're doing in Kansas City and in Chicago. They're doing something very similar in Boston and beginning to do these things in more remote and rural areas as well. The Providence Health System, I worked with them for 2 years, and they have hospital systems from Alaska to South Dakota to Texas. Some are very remote, very rural. One of the areas that they looked at is white, rural, poor, older people in Washington State, and how they can then collectively work with those communities to deliver, in that case, more effective, more efficient telecare services. So begin to think about what your architecture should look like, who you can work with in partnership becomes really important.
Yeah, and we'll talk more about this at our faculty meeting next week. Because as Dr. Wyatt says, we won't solve the poverty issue of the state. But I think the perfect example he just referenced with our ability to provide telemedicine and our expansion in that space and how we're doing outreach and the increase in resources we'll see in providing patient navigators and that type of care as we partner with Peak Health going forward. And so I think there's a lot of opportunity here for us.
Now, I'll mention real quick, I know we're out of time, another group that I'm working with is American Telehealth Association. And we put together over the last year and a half a framework for delivering effective, efficient telehealth. Something we discovered, and we're now having discussions with a couple of internet service providers about, is how bandwidth to certain geographies is being throttled. And that's not new. So we're asking, and we've now created a map to show how bandwidth is throttled to low-income communities, how bandwidth can be throttled to rural communities, as opposed to higher income corporations, et cetera. So there, and I won't get too technical. We're looking at latency speeds, upload and download speeds in more remote populations. And we're saying to internet service providers, you know, if we create a telehealth, telecare service, we need to make sure that it's effective and efficient, and you're not throttling the signal because it impacts clinical decisions and outcomes. It damages trust inside the organization if that service is not efficient. So as you build a telehealth service, I think it's important that part of that is to have those discussions with the internet service provider to say, do not throttle our signal to remote and rural areas. And then look at ways, and we even looked at ways to deliver telecare services to a tent city in Portland, a tent city in San Francisco, how we can bring those services to a local pharmacy, to a senior citizen center, to a community center. What are those other areas that we can say, here is the West Virginia Health System telecare service that you can come in and access care, but it cannot be throttled for economic purposes.
Right. Some of the world's best problems are best addressed from the bottom up, not the top down. Any ideas how we can incorporate that as a solution?
Yeah, so my quick answer, and that's a complicated question. My quick answer is partnering with the community. And that has to be done with humility. And sometimes that's a challenge for us, but go into that community where they're doing stuff and asking, how can we serve you? Right, and recognize, and this is not something that I discovered. I'll give you an example of a Bowers Award-winning system whose patients left them. And when they went to the community told them, you stopped serving us, you were too self-serving. They apologized to the community and said, we are sorry, we lost our way. We want to be servant leaders for you. How can we serve? And I will guarantee you, you will develop trust and partnerships that you didn't think you had before. So I would say, take that approach. We're not going to have in this system all the answers, but the solutions are out there. If you go with humility and say, here's what we're trying to do, and we're not going to desert you. I'll give an example. The Providence Health System has gone through major financial upheaval like many systems have over the last 2 years. On paper, they have lost hundreds of millions of dollars. They had massive layoffs, even at the senior and executive level. That system, however, committed $50 million to health equity. On their last call with us, the CFO, Chief Financial Officer, was on the call. And he said, we will continue to support you, and that $50 million contribution to help the community will not go away. Because you can imagine what happens if a system now says, we're going to work with you, and then somewhere the money goes away. You've done more harm than good, and it will take you years to regain that trust if something like that happens. That's why strategic planning becomes important. Don't commit or promise to something that you can't do and can't sustain. You do more harm than good. But go to the population, go to the community, go to those churches, religious entities, sororities, fraternities, civic organizations, whoever they are, to show that you're committed to this and you're there to assist and serve, not to tell people what to do.
Just another comment of, unfortunately, schools, I see big disparity and equity, different levels, but one day we have a better place and give equal opportunities for kids. I know system is acknowledging
I agree.
that. Yeah. And I think just from everyone, thank you so much for coming and for your time, and all of your knowledge. We really appreciate it. Any other thoughts or comments, you can reach out to our email and we'll try to get them to Dr. Wyatt as well. Thank you so much.
All right, thank you. Oh, I wasn't supposed to say roll tide, but I will. I did say it.
Got it.